Warm greetings to you all. Today we will be discussing on degenerative disc disorders. Before that, we will be revising some of the basics of the spine. There is something known as functional unit of spine. As you all know that spine as a whole is a complex structure. So we can make a component of a spine which represents as a spine in a whole. So that individual component which represents as a spine and acts as a biomechanical work as same as the spine is the functional spinal unit. So the functional spinal unit is the shortest segment of the spine to represent biomechanical characteristics that resemble those of the entire spine. Means that what is the function of spine? This functional spinal unit does the same as an individual component. So we need to know what does the functional spinal unit consist of. The functional unit of spine consists of intervertebral discs, two vertebrae below and above, and because of that there lies one important structure called in-plates of the vertebra. And then you see here the posterior segment, and here you see one joint is there. This joint is known as facet joint. So mainly these three structures, they act as the functional spinal unit. They are intervertebral discs, in-plate of vertebra above and below, and the facet joint. However, different ligaments like anterior longitudinal ligament, posterior longitudinal ligament, and other ligaments also falling in this compartment act as a functional spinal unit. Now you can see in the spine, you see here, so this is the vertebral body and this is the another vertebral body, isn't it? And in this between this vertebral body lies the intervertebral disc. So your intervertebral disc lies here. Intervertebral disc is divided into two components. So you see here, this is the horizontal section. The center core, which is jelly-like substance, it is known as nucleus pulposus, and the fibrous band surrounding around the nucleus pulposus is known as annulus fibrosus. So let's see what is nucleus pulposus. Nucleus pulposus is nothing but remnant of an embryonic notochord. Here, the important thing to remember is that the nucleus pulposus consists of high amount of proteoglycan. What is its significance then? High proteoglycan being negative in charge, it attracts water, means it is hydrophilic. Because of hydrophilic nature, it hydrates the nucleus. And when it hydrates the nucleus, its morphology is like a jelly substance. So this is the inner core circular structure which is nucleus pulposus. It is jelly-like, J for jelly, isn't it? And because of this jelly-like elastic property, when there is axial force working on it, suppose you have the axial force working on the nucleus pulposus, it goes certain morphological transformation and it distributes the axial force in horizontal direction. So this benefit is seen because of the hydrated nature of the nucleus pulposus. And because of this, when the horizontal force is transmitted, the annulus fibrosus, so this annulus fibrosus, they cancel out the horizontal force, and as together they act as a shock absorber. So this is the importance of the hydration state of the nucleus pulposus. But during the aging process, what happens is that the content of the proteoglycan is decreased. So your proteoglycan is decreased. Because of that, there is poor hydration. And because of this poor hydration, there is loss of normal biomechanics. And because of this, different problems can be seen like disc prolapse, so on. Another structure is annulus fibrosus, as we have already discussed. Now here the important thing to learn is that it is highly rich in collagen and it gives the tensile strength and it counteracts the horizontal force. So here the horizontal force was provided by nucleus pulposus. Initially the vertical force acts from above to down and this force is transmitted horizontally, and this annulus fibrosus they neutralize this horizontal force and act as shock absorber. One important thing you need to know is that the anterior part of nucleus fibrosus they are somehow stronger in relative to the posterior part. So most of the disc herniation they take place from the posterior part. What are vertebral in plates? So you see here, this is the region which denotes intervertebral discs. So in above and below the intervertebral discs being attached to the vertebral body lies the vertebral in-plate, which is fibrocartilaginous structure. And for now, what you keep in mind is that the end plate of the vertebra acts as the important source of nutrition for the intervertebral discs, and this nutrition is provided via diffusion. Now let's learn how does the intervertebral disc gets its nutrition. One I have already told you, here lies your end plate of the vertebra. So from the end plate of the vertebra, by the diffusion process, the nucleus pulposus gets its nutrition. So this is the nucleus pulposus. So because of diffusion, the nucleus pulposus gets its nutrition from the end plate. And you see, in the periphery of the annulus, you can see there is vessels. So from there, the periphery portion of the annulus fibrosus gets its nutrition. So here the important thing to keep in mind is that nucleus pulposus is a avascular structure. For that, diffusion process from the end plate is must for its nutrition. But during aging, what happens is that the end plate there can be sclerosis, or because of smoking or because of atherosclerosis, the vascularity of the vertebral end plate they are decreased, and because of that diffusion of the blood vessels or the important nutrient can't take place, and because of that the hydration property of the nucleus pulposus is slowly decreased, and this phenomenon is seen in degeneration. Now when there comes different terms like disc degeneration or disc prolapse, then the patient often complain with pain. So we need to know what are the pain generators. In the intervertebral discs, as we know that annulus and end plates are the structures that have access to neurovascular. So these source act as a pain source. However, when there is inflammation going on, then there takes the neovascularization into the nucleus pulposus, and at that time it also can act as a source of pain. As I have already discussed, during degeneration process or during disc prolapse, certain chemical pro-inflammatory substances such as prostaglandin E2, prostaglandin F2 alpha, nitric oxide, they are released. And when these chemicals they come into the vicinity of the nerves, they produce chemical irritation. And because of this chemical irritation, the patient complain of pain. Sometime because of disc degeneration and disc prolapse, suppose this is a nerve going on and from here your discs get prolapse, and because of this disc prolapse, because of mechanical compression to this nerve, there can be mechanical source of pain. One correlation you can see here, these are prostaglandins which give rise to the chemical irritation and pain. So these steroids they are used which antagonize the activity of prostaglandins, and because of that the patient gets relief from the pain. Now the most important slide of today's lecture is this, which indicates the biomechanics of intervertebral discs. Slightly we have already discussed, now we will be discussing it in a great detail. So you see here, when the axial force is acting from above to downward, the nucleus pulposus, because of its property, what it does is that it centrifugally distributes the vertical force as same as the Pascal's law. And because of the centrifugal distribution of this force, some force act here, some act here, so some force above, some down. And you see, gradually when we sum up the vector here, these forces tend to act horizontally. And when this horizontal transmission of the vertical force takes place, then comes the role of annulus fibrosus. So what this annulus fibrosus does is that, so you see the annulus fibrosus, they are arranged in a spiral network like this. So this spiral network, what they do is that they antagonize or they cancel out the horizontal force. And because of this, they help in neutralizing the centrifugal force and balance the vertical load bearing. So you see here, there is application of the axial load. After application of the axial load, the jelly-like consistency of the nucleus pulposus undergo compression, and then it centrifugally distributes the compressile force. Because of spiral orientation of annulus fibers, they neutralize the centrifugal force. And now, on removal of the vertical load, because of the elasticity of the nucleus pulposus, it again regains its normal dimensions. So in this way, the spine acts biomechanically. Now let's move towards the natural history of disc degeneration. Kirkcaldy and Willis' hypothesis is the most to understand the natural history. It indicates that three phases takes place during disc degeneration. The first being the dysfunction, instability, and re-stabilization. So what happens in dysfunction phase? During dysfunction, as we already told, that nucleus pulposus, it is hydrated. So during aging process, the hydration is lost, the proteoglycan content is lost, and because of that, it cannot maintain its elasticity, and because of that, it cannot transmit properly all the amount of vertical force horizontally. And because of this dysfunction, different pathological findings can take place, like circumferential tears and radial tears can take place in the annulus fibrosus. So this annulus fibrosus, because of mechanical load, they tear up. Since I already told, most of the weight transmission is done from the anterior segment, but when different dysfunction pathology takes place, then the force is transmitted to the posterior segment, and because of this we can see synovitis and hypermobility of the facet joint. And in young age, especially between 35 to 55 years of age, there can be dysfunctional and herniation of the intervertebral discs. Now, in instability phase, what happens is that the degeneration is ongoing, and because of that, there is a resorption of the hydration. And because of this, you see here, posteriorly, the height of the intervertebral disc has decreased. And you see, maximum amount of anterior force has been transmitted to the posterior segment. And because of this, there is instability of the three joint complex now. When instability is taking place, there is resorption of the disc going on, and there is capsular laxity and subluxation in the facet joint, and sometimes it can lead to lateral nerve entrapment. Now in re-stabilization phase, it especially takes place in older age. What happens is that because of continuous involvement of the facet joint, load bearing and hypermobility, now osteoarthritis like features takes place. There is enlargement of articular process, osteophytes that form in the vertebral bodies as well as in the facet joint as well. And because of this ongoing degenerative process, there we can see stenosis of the canal, vertebral canal. So in a nutshell, we do need to remember the first being dysfunction. So ongoing degenerative process is taking place in the intervertebral disc. Then comes the instability, and after instability, what it takes place is that the body works to restabilize itself, but at the time of restabilization, it has to pay. It pays by decreasing. You see here the intervertebral disc height has been decreased, osteophytes they are formed, pain source, and you see this joint they are also hampered, and because of this the process goes on. Now we see the etiology of disc degeneration. There are four basic main etiologies. They are: first being the aging process, another being the mechanical load bearing, another being the structural changes, and the most important thing is the genetic changes. Sometimes because of the nutrition, because of the vertebral in-plate defect by which it cannot supply the nutrition properly, sometimes metabolic factors like thyroid disorders, sometimes toxicity because of smoking, and sometimes chemical pro-inflammatory messengers. It can also be because of the immune, because when there is disc rupture or because of degeneration, it is said that the nucleus pulposus is it is like immune free, like it has not been the antigen of it has not been presented to the body. So when there is disc prolapse and the content of the nucleus pulposus is exposed, then autoimmunity sets in. And sometimes there is infection of the vertebral in-plate, propionibacterium acne, and because of these infections also it has been proposed that the disc degeneration sets in. And neurogenic, there has been studies which shows that substance P, because of the release of the substance P also disc degeneration process is going on or aggravated. So this is the multifactorial process you can see here, and most important being the aging and the mechanical factors and the genetics. Now we will discuss one by one. So aging, what happens in old age? In old age, the rate of synthesis and concentration of the proteoglycans decreases. As we have already told, what are proteoglycans? Proteoglycans, they are hydrophilic, means they tend to attract water. So when the proteoglycans is decreased, then the hydration property of the nucleus pulposus is decreased. And you see, we discussed that the nucleus pulposus is made up of collagen type 2. During aging, they are replaced by type 1, and we know type 1 collagen, they more potentiate for calcification. And in the intervertebral discs, non-collagenous proteins increases in the nucleus, and because of this less proteoglycan and other amount of proteins, so there will be less amount of water binding to the less amount of proteoglycan. And as a result, because of dehydration, the nucleus becomes progressively more solid, dry and granular. So does in this way it can perform the normal biomechanics? No, it can't. Mechanical factors. As you know, during aging, different changes takes place, but there are other factors that indicate that mechanical factors are important for the disc degeneration. One being is that, suppose this is our spine. Since the vertical force is acting all together, isn't it, to every segment, and aging also it starts all together in every segment, But we see the maximum defect is seen in the lumbar region. Why is it so? Is it only because of the aging? No, it is because the mechanical force they tend to act repeatedly in a prolonged way in the lumbar region. So the mechanical force effect is mostly seen in the lumbar region. And one thing here I have mentioned concept of adjacent segment disease. So what does it mean is that during scoliosis, what it was done for treatment was the fusion of the spine was done. But when there was fusion of the spine, the adjacent structure lying below this fused part underwent degenerative process. So what does it mean? So is that during the mechanical force transmission, maximum impact was seen in this vertebra because of the fusion. So, the mechanical factor is one of the most important factor that initiates the disc degeneration. So, different activities like heavy weight lifting, truck driving, and heavy physical works. Truck driving, in a sense, because of the vibrations. So when the vibration of our body or the external environment it matches with the normal vibration of the lumbar or the any other vertebra, then it is said that the degeneration process is aggravated. And frequent bendings, and you know that porters they bend and carry the load, so maximum tension is seen in our spine during this posture. While lying supine, the tension is least. While standing, it is a bit more. While sitting, it is again a bit more. And while bending forward, it is maximum. So this thing you keep in mind. Nutritional factors, as I already have been discussing again and again. So in-plate sclerosis can take place in aging process. So because of this, it impairs the diffusion. Different conditions like atherosclerosis, sickle cell disease, they can also lead to nutritional defect to the nucleus pulposus. Calcific changes seen in the uh, vertebral in plate, and because of the smoking, the in artery vascularity, you see here the vascularity is being decreased. There is sclerosis and calcification, and because of this the nutrition content can't diffuse into the nucleus pulposus. And when the nutrition component is lacking, it undergoes dehydration, and because of dehydration it undergoes degenerative changes. Genetic factors is beyond the scope of today's lecture. However, we need to see that different collagen like collagen type 9 and matrix melanoproteinases 3, so different genetic profile have been identified that have been related with the disc degeneration. And you can see here pro-inflammatory like interleukins 1, interleukin 6, they have been also found that they have role in disc degeneration. Etiology of disc degeneration. So what are the other etiologies that I have already discussed? When there is low grade infection of the vertebral in plate, especially because of the propionibacterium acne. So it has been also proposed that because of this also it triggers the disc degeneration. And another being the autoimmunity, because nucleus it has been proposed as the concealed antigen. So when there is any degenerative process going on and the content of the nucleus pulposus when they gets released into the bloodstream, then it sets in autoimmune process, and because of this it aggravates the disc degeneration. And another being the smoking, which is toxic in nature and it hampers the nutrition by decreasing the vascularity of the in plates. Now let us discuss what are the clinical features of degenerative disc disorders. One, commonest and the foremost being the low back pain. And what type of low back pain is it? It is axial. Axial in a sense, suppose this is your trunk and here is your spine. So axial means relating to this area, to the center core body only. Okay, so the pain especially they get localized around the vertebra. It can go towards the buttocks and thighs, but more or less they are in the center line of our body. And this pain they are aggravated on sitting, prolonged standing, and usually relieved by lying supine. Because I have already told you, when lying in a supine, the mechanical force acting on the spine is the least. Another thing to know is that radicular pain. So what is radicular pain? Sometimes when there is disc degeneration or disc prolapse, what happens is that different chemical messengers, as we have already told and discussed, that prostaglandin E2, prostaglandin F2 alpha, they release and they irritate the knob. And because of this irritation, it gives rise to chemical pain. Another thing is that because of the disc degeneration and bulging or prolapse, it can entrap different knob roots and knob. So because of that, there gives rise to the mechanical pain. While seeing a patient, we need to rule out fever, whether there is any infection or it can be because of the spine TB. So evening rise of temperature, that also should be needed to be ruled out. And rest pain, if there is pain at rest, then it can be a warning sign to the clinician. Recent UTIs, night cries because of the infection, it can be non-malignancies because of the malignant they have, it can be migrated to the spine also, it can be. And another most important is the cauda equina syndrome. It is the orthopedic emergency in which the cauda equina gets compressed because of the disc prolapse, and because of that it is the orthopedic emergency. Because when surgery is done, decompression surgery is done within 48 hours, then the maximum prognostic is seen. But when it is done after 48 hours, then especially symptoms like incontinence and other things they remain. So it is the orthopedic emergency. And there can be history of recent trauma, steroid use, which can be pointing towards the fracture. So these things need to be ruled out. Now, while talking about the diagnosis, we need to look at the imaging. Initially, the step one imaging is done by X-rays. So plain X-rays, we take plain X-rays. Some cases we may not find any changes, but in most of the cases we find different changes that takes place. So we see here, what are the different changes we see? Reduced disc height at affected levels. We can see sometimes in-plate sclerosis. There can be presence of osteophytes, and there can be vacuum phenomenon. Vacuum phenomenon is nothing but because of gas accumulation, we see dark field, and that dark field is of course called vacuum phenomenon. So you see here, what are these? These are your vertebral body. Now see, you see here, this is intervertebral disc. This is intervertebral disc. Now you see, you measure the height. So you see height, it is comparable. Here it is comparable, but you see here it is markedly reduced. So here the height of the intervertebral disc, here it is decreased. You see here, here also it is decreased, isn't it? And here also somewhat it is decreased. So you see the disc space or the intervertebral disc height has been decreased here. And you see here, so increase in white density is seen here. This is nothing but because of the sclerosis or calcification. So you see here around the in plates. So these are nothing but they are the sclerotic in plates. And you see here different projection you can see here, isn't it? These are the projection you see. These projection are nothing but osteophytes. So we are seeing all three things from here. You see reduced disc height. So you see here the height has been reduced. You see here disc height has been reduced, and there is sclerosis of the in plate here and here, and different osteophytes we can see here. You see here, these are the osteophytes. You see the pointed projection from the vertebral body. So these are the osteophytes. MRI is the another step to investigation, in which you can see again reduced disc height, loss of T2 hyperintensity in the nucleus pulposus, plate sclerosis. You can see marrow edema because of inflammation on going on there. And there are two terms, modic changes and Perman's classification. So we will be learning these two things in more detail. So while doing MRI, there is modic changes or modic classification. So in T1 and T2, you find different things. How I remember is that in T1, I use a mnemonic. One thing you keep in mind is that in modic type 3, in both T1 and T2, there is hypointensity. Hypointensity means dark. So you see here, this is also dark, and here you see also dark. However, in case of T1, it is hypo, hyper, hypo. So in modic type 1, it is hypo, modic type 2, it is hyper, in modic type 3, it is hypo. Again in T2, however, it is hyper in modic type 1, hyper or iso in modic type 2, and again hypo in modic type 3. So you see here T1 signal. So this is T1 signal in modic type 1. In T1, so in modic type 1, so you see here, this is hypo, dark field. However, it is hyper intense. In which case? In this case. So first of all, let's see only type 1 only, okay? So in type 1, as I told, there will be hypo, hyper and hypo. So you see this is modic type 1, which is hypo. Here again type 1, here it is hyper intense, you see hyper intense field, and again dark field, which is hypo in T1. So in T1, what you see? Hypo, hyper, again hypo. In T2 signal intensity, what you see is hyper intense. You see here hyper intense, increase in whiteness, hyper intensity, and again there is whiteness, so hyper intensity. But you see here blackish or hypo intensity. So hyper, iso or hyper, again hypo. So what are these changes? These changes are marrow edema, fatty infiltration, in-plate sclerosis. So this modic 3 is in-plate sclerosis, which is taken up as hypointensity in both T1 and T2. M2, it is fatty changes, hyperintensity in both T1 and T2. M1, it is nothing but marrow edema, which is hypo in type 1 intensity and hyper in type 2. So this modic classification we need to know. Now we see Firman classification. It gives grading, and this grading is divided into 1 up to 5. So in grade 1, so you see here, it will be clear to you, grade 1, 2, 3, 4 and 5. In grade 1, the nucleus pulposus, it is homogeneous. You see here, it is homogeneous. It is clear, clearly distinguishable. However, in grade 2, it is inhomogeneous. Certain band-like structure you can see here. However, it is clear. But in grade 3, it is a bit unclear. It is inhomogeneous. In grade 4, you see the height is now gradually decreasing. The height of the intervertebral disc is gradually decreasing, and you see that it is inhomogeneous and it is unclear and it is indistinguishable. In grade 5, the height has been completely collapsed, isn't it? The height has been completely collapsed. It is indistinguishable, it is inhomogeneous, and it is black. So you see, from clear to gradually unclear, homogeneous to gradually unclear, height has been gradually decreasing. It decreases in grade 4 and completely collapses in grade 5. So these are the properties you need to know. So here you can see grade 1 white and homogeneous, it is clear. In grade 2 inhomogeneous banding but it is clear. In grade 3 it is clear, inhomogeneous and unclear. It is gray, inhomogeneous and unclear. In grade 4 it changes gray to black, it is inhomogeneous, distinction is lost. You see here, can we distinguish nucleus pulposus and nucleus fibrosus? No, we cannot. In grade 5 it is completely black, inhomogeneous, indistinct and the height is collapsed. You see here, collapsed. So height has been tending to decrease from grade 3 to 4 and it is completely collapsed in case of grade 5. Now what are the treatment modalities? Two types of treatment modalities are there, non-surgical management and surgical management. And these days newer guidelines tell that the surgical management are not advocated in case of degenerative disc disorders. So initially we need to go for non-surgical management. So in non-surgical management we have medications and we have physiotherapy. One thing we need to keep in mind is that both medications and physiotherapy need to go side by side for maximum patient outcome. So only taking medications alone can't help and only physiotherapy alone will not be helping in an utmost way. So for better prognosis and better outcome, medications and physiotherapy need to go side by side. And the ladder pattern of analgesics need to be followed, which means initially NSAID low dose, then NSAID higher doses, and if it does not take place, it does not relieve, then we go for opioids, and sometimes tricyclic antidepressants may also be advocated. Physiotherapy, these are especially back strengthening muscles exercises. And other modalities is injection therapies. In injection therapies, we provide steroid injections. As you have already told, different prostaglandins they are produced, which act as the chemical source of pain. So chemical pain source. So steroid injections they are given. And then we have something called ozone therapy. It especially works by decreasing the content of the nucleus pulposus as a whole. And there are electrothermoplasty methods and hypertonic dextrose infusion injection has also been proposed. Other newer modalities that have been especially worked and investigated in animal models is disc regenerations. There are stem cell injections, recombinant growth factors, and gene therapy. In gene therapy, viral vector has been used, which is effective, and it replicates, and then it has greater prognosis because that the gene it remains in the memory of everlasting until the patient dies. So gene therapy is the best one, but these modalities are under investigation in animal models. Surgical management, fusion technique like posterior lumbar interbody fusion technique or transforaminal or anterior lumbar. Most of the case posterior lumbar is the commonest done one. Sometimes anterior and posterior both we can do, and in some cases total disc replacement has been tried, but the outcome which it was supposed like it will have utmost benefit, so while further investigation that benefit was not seen, so it is also in doubt. So this much all for today. Thank you, have a wonderful day ahead.